Cletus, you've already been on stage, but just introduce yourself for those that don't know you.
Yeah, again, Cletus Earl. Today's hat
Yeah.
is as the board member for health system. So again, from a perspective of a former CIO to a board member.
Awesome.
I'm Tom Hallisey. You haven't met me, many of you. I have to say that Cletus is the first, now second unicorn that I've ever found, which is a CIO who's become a board member, which is what I am. I now work at the Healthcare Association for my day job, but hospital board member, and I also teach a class, graduate course in managing health information technology at SUNY Downstate. So good mix.
Fantastic. And I'm nowhere even in between you two, but a pretty different perspective. Chief Marketing Officer at Premier, which, if you know Premier, an alliance of hospitals and health systems, about 76% of all hospitals in the nation. For Premier, I own brand and reputation. I own a lot of our AI roadmap. Surprisingly, that's a marketing-led initiative. And I own our partnerships. So that's my perspective today.
Awesome. No, what I wanted to start with is maybe even just give some colorful comments on what Mohan talked about, and then we'll get to the more practical aspects. But there's just so much, and my viewpoint of this is I'm also an advisor at a couple of universities for their advanced data science programs. So the idea that how do you teach kids to be able to pull together data and do stuff with it, right? And the problem that we've been having is that we've been directly lying to our students, right? This is the problem where we say, don't use AI, and then we know that they're using AI, and so we accept that they use AI, even though we tell them not to use AI, and now they're kind of confused, like, is it okay? Is it not okay? And that may be a kind of like a problem, even though almost here, everybody, we didn't even talk about the fact that even in many institutions today, the AI is locked down. Not everybody can use each model, et cetera. So you guys can certainly talk about that. But this idea that even at universities, we're lying to our students and telling them something is not allowed, but knowing that they're doing it and still accepting them and moving this forward means that we're in this little weird scenario for the next several years where senior executives absolutely don't have the answers, but we don't know how to say we don't know, and yet try to get our staffs and colleagues, et cetera, to help us improve our own knowledge and move this forward. So I'm like totally confused and would love to see if you guys have any thoughts on how to clear.
I'd love to jump in first and say that in my class, depending on the assignment, I encourage AI use.
Good.
So there's one assignment where, build a business plan for instance, ambient AI at your facility. And I say to them, look, I know the school tells you can't use it, but if you're in the real world and you're writing a policy or building a business plan and you're not getting started with that, you're wasting a lot of time. To your point, that's not the mind piece. Let's get that out of the way. Here's a template. I got to start. But yeah, then you have to teach the difference. What's that piece you're adding that comes from you? And that is the difficult part. But it's very interesting because I also did it with just a policy. And someone said in the class, there's a physician who said, won't that just be incredibly easy to write the policy then? And I said, yeah. Policy is not, we're not looking for innovation necessarily in a policy here. We just want a tool that helps us run whatever it is we're trying to run in that particular case. So yeah, it's an interesting case there. And I love what you said about you could tell the difference. And I explained to the class as well, that I can immediately tell whether you've adjusted, reprompted, made your own edits, explained different ideas to the AI, or just used it. And then what I also do is, sometimes I do this after and don't tell them I want it before. I say, now that you've turned it in, give me all the prompts you gave to get this out so that we can look at how that flowed and how it worked. And a big part of it for me isn't necessarily there. This is how they'll build it in the real world, but this is learning how to work with that tool and what aspects to give it a view, as you mentioned, and what aspects can it do well.
So I love your viewpoint from, obviously you guys have a lot of members. are members coming to Premier to ask you your opinions about what you guys think, or asking you how are others handling this? They come to you for that kind of advice around AI?
They are, I'd say in learning mode and also looking for models to really understand what the return on investment is. And not only from a financial perspective, but also from a workforce perspective, from a patient satisfaction and kind of building trust perspective. So we're trying to convene groups of like-minded health systems and hospitals, both in the rural space, but also the large IDNs that are kind of learning together, establishing governance principles together. One thing that Premier does really well is scale.
Mhm.
And so instead of a one and a one and a one, what does a global government's framework look like? How do we establish and ask vendors for a return on investment calculation? I think your comments are so interesting. I always say I went to business school to learn how to present because before business school, I never really had to like defend my ideas in front of people and stand up. And I think that storytelling element is what we're missing. We just announced a $100 million investment in artificial intelligence to really kind of enable the healthcare supply chain transparency and predictability and when the business teams and the technical teams were preparing for the board meetings, they kept bringing me this stuff that was AI generated, and I could just tell. I'm like, there's no story here. So I feel like we really, and the health systems are looking for this too, to go to their boards and get an investment. We have to tell the story, and that needs to come from us. That needs to come from the patient perspective. That needs to come from the consumer's perspective, the clinician's perspective about how this is going to make things easier for them. Like that storytelling element, we can't lose.
So given your Premier place as helping with GPOs and helping groups buy things together, what is it about what you guys have done for years now that could assist with your, talk about it in collection, talk about it in scoring? This is one of the reasons why hospitals and health systems are kind of stuck. There's just like an abundance of choice. So instead of moving, they're kind of like stuck a little bit. Do you see that is, are they stuck? Am I giving you some accurate assessment there? What could a Premier do to help them with that unstucking? Because then if you do it together, you feel better, right? So is that happening a little bit?
It's all over the map. I mean, some are investing so heavily and spinning out companies that we're acquiring or partnering with or helping to scale some of the more advanced health systems.
Any
But
examples that you could give?
well, an example being Cedars-Sinai. About 6 years ago, actually, we bought a clinical decision support tool out of Cedars-Sinai, and we've scaled it across 200,000 clinicians across the nation. So some of the innovation is actually coming from the systems themselves, but then some are just looking to say, I can't afford to spend a little and a little and a little. So what are the tools that are really going to transform the way in which our workforce operates, not piss our clinicians off because we're already trying to retain them and, make them happier and make their jobs easier and not erode trust with our consumers and our markets, right? Which is a really big deal for them right now.
Yeah, so Cletus, so one of the things that we see with this particular technology on the AI side and more on the generative one rather than prior generations is boards are more actively wondering what their C-suites are doing. One, do you feel that's true, or were they always involved in technology and we just didn't hear about it before? Or are they more involved in this technology from the board level? Why is that? And then what could boards be doing to make that job of making decisions easier for C-suites?
Yeah. So AI now is so pervasive. It's everywhere. So if a board is not talking about it today, I don't know what you're doing because it's remember, these are business leaders. These are people who have their own expertise. So they have AI being used in their respective areas as well. And of course, when there's challenges or opportunities in the health system that they basically sit on the board, they think, well, can't you use those technologies as well? So that's always being brought up and having that expectation. Now, the thing about it is, as a board member, we have the fiduciary responsibility regarding risk, right? So it's very, very sensitive when you talk about using this technology, particularly when it comes to the medical record, and in most cases, when we talk about LLMs, right? You notice we didn't say LLM, right? The localized large language modules. We're talking about the local ones, which are residing most of the time outside, the chats, the generatives, those kind of things, where people are putting the, in some cases, PHI or whatever it is, out in the ether. And as a board member, that terrifies us because, again, having the fiduciary responsibility, that means I personally can be sued. I want to be very clear. I personally, my house can be up. Yes, we have insurance. We have board insurance policies. I get it, but that's terrifying to us, right? So it's not just the institution. It impacts us personally. So we want to make sure that all elements are protected. And yes, you do it, and you do it with a lot of intentionality. Now, I'm going to back up for a second. CIO hat. When I was the CIO at Penn State, I was not only the CIO, but I actually went back to do my doctorate. So kind of going back to also being the client.
Mhm.
And as a student, I found it absurd to think that you can put that a cat back in the bag.
Mhm.
Just can't, right? We are using it. You're absolutely right. And as a CIO, then I had to incorporate tools to detect AI, usage inside people's projects. But then, AI is fighting AI, and then they're using counter programs, and
Mhm.
again, doesn't make any sense.
Mhm.
So from multiple perspectives, whether it's a CIO, whether it's a student or a board member, it is imperative that we need to embrace the technology, but embrace it with thought, with practicality, and with protection and security at mind. So
Mhm.
again, I'm answering your question to say a lot of organizations are coming to the table and expecting it, but we need it to be presented to us in a much more thoughtful way so that we're mitigating as much risk as possible to our patients.
Yeah, so one of the, and I'll let you jump in. One of the ways that we've always talked about this in the last couple of decades is give people room to fail, because that's failure will then get to learning, as Mohan mentioned a little while ago, is if you try things over and over again and then you win, it'll be in your brain better. So what does that look like in this AI? What does that room to fail look like for you guys? What do you advise?
Yeah, I advise people again to do the localized model, right?
Okay.
Do it in a sandbox, just create your own sandbox, create your own environment where you can actually kick the tire without mitigating risk. De-identify. We've heard that a lot over
Mhm.
right? Again, heard a lot of good discussions like that. But doing it in a localized manner, if you have the ability, right? If you
Yeah.
have the technology, again, if you're a university, a lot of organizations have HPCs, high performance computing. You have the ability to do that. You can actually do LLMs in a box, right? And again, it takes skill,
Mhm.
but I think what you should be able to present to organizations, even if you're not a big one, be able to say, how do we do it within a confined construct, or partner with your local institutions, your local universities, to be able to do something that's more secure,
Yeah.
right? In the Hudson Valley area, as a CIO, we worked with SUNY New Paltz, right? In that very same case, we didn't have it in our health system,
Mhm.
but we worked with the university, dotted all the I's, crossed the T's, and we did some really great localized methodologies there. So there's always a way to be creative. You
Yeah.
just don't get caught up in it. So you can move forward, but again, be cautious.
No, I love it. So similar question for you.
Well, and we spoke about it a little last night, but I wanted to bring up a specific subject about the disconnect you mentioned that exists now. And as we discussed, it's about open evidence. So does everybody know what open evidence is? It's
Show of hands, do you know what open evidence is? Yeah, can assume so.
so it's basically the chat GPT for physicians. That's a pretty dumbed down version, but that's as far as I'll go right now. So if you have an MPI number, you can get that free. And so I bring it up because I travel a lot to all the health systems, and I speak to them, and I'm on the boards and meeting with the trustees. And I visited a bunch of sites where physicians, including the CMO, the dean of the medical school at different facilities, explaining that you can use open evidence. It's great. And I don't give it the patient ID, so it's fine. There's no privacy issue. You see, Cletus is not handling that well.
He's right on board.
I've gone to the same institution where I've heard that and then heard from the CIO, oh, we blocked that. So we've got this huge disconnect. And as I dug into this, preparing for this, because that was the first question that was proposed for here, where's the disconnect? And as I dug into this, first I looked at open evidence. Really, we only started to hear about it barely a year ago. It's now used by more than 40% of physicians in the US. 65,000 new physicians sign up every month. And as I looked at that, you think, well, this happened without everything we said the last 2 days, right? I think of the good old Dr. Seuss in The Grinch Who Stole Christmas, when he says it happened without ribbons, it happened without tags, right? It happened without training, it happened without education, it happened without integration, it happened without workflow design. And then the more I thought about it, I thought, wait a minute, did it happen because of those things, not in spite of them? Is this because none of those physicians, no offense to any of them, tested all 50 tools that were out there and said, this is the one I want. A lot of their employers were trying tools like this. A lot of them may well have had pilots going on where they could have used that. So the more I thought about it, the more I thought, I think this is intentional. Maybe not on purpose, but it fits, Mohan, with what you were saying. You know, I use the example because I'm not a physician, of the simplest thing I could think of, which is driving your car. And we heard from Dr. Bhutan just a couple sessions ago about the noise. When I drive my car and all the alerts that I didn't ask for, I get worse. I get worse at parallel parking. There's no question about it. But when I go into reverse, the camera comes on. And my wife thinks this is hilarious, but I say to myself, I don't want that thing. I can turn around. I need to see the sidewalk and everything anyway, but it's there. So I better look at it, because now, you know, the neighbor's cat could be under there and I can't see it any other way, but now it would be my fault because I had that tool. And I feel like that's part of what we're hearing from the physician here. We're not listening. We don't want this built in. We don't want another paperclip telling us what to do. We don't even necessarily want it always on. What we want is the PDR that was under our control, the physician desk reference. Desk, it's over here. I decide when to use it. It's not on all the time. And you know, one of the top two items that physicians fear with AI is liability, they refer to it. But we had somebody explain yesterday that it's not really liability. They're not going to get sued for not looking at it. But I don't think it's a liability thing. I think it's like my camera. It's killing the cat thing. They feel responsible for these patients already. You've put it in front of them. I guess I got to look. I guess I got to let it go through that, even though it's a broken ankle. I know what's going on here. But now I feel somewhat obliged to do that. Rather than I'm completely in control of this, it's a tool over here, and I'm still making decisions and using my mind most of the time. So I present that as everything we heard today. This is the opposite. But just an FYI, a recent survey said that 84% of physicians who are using that tool said it makes them a better doctor. How many tools have we installed as CIOs where they came to us and said that? Sadly, I can't think of any. And they did this without us. So I don't have the answer to where this leads us, but I think it's important to note that, particularly as we look at future user design and where this fits. You know, on top of this, many of you probably heard last year there was in radiology, there was a study that looked at Radiologists versus AI versus the two together. Guess who was worst? Anybody? The two together came out worse. So we talk a lot about augmented AI, but maybe we're not there yet. Maybe we don't understand this user interface. So I loved what you were saying. Like this somewhat blows this all up a bit. And maybe that's where we get. And maybe your current 10-year-olds are going to use augmented AI. And maybe it's the 40 and 50-year-old physician that isn't ready for that. But we need to consider these options.
No, definitely. And can you
I-
comment whether or not open evidence is on Premier Catalog, or do you,
It is
you
not
guys-
currently, but what I will say is in my industry, we call that product market fit.
yeah.
And you know, so often we talk about healthcare data, but aren't the clinicians the last ones to actually be able to utilize it in a way that identifies patterns and helps them improve? Administrators are using it from a dashboard perspective to manage down. You know, maybe patients are using it from an outcomes perspective to say, I want a different outcome. But when was the last time it was opened up to a clinician to actually help them improve? We learned this the hard way, that AI has to be a very use case driven approach. When 6 years ago, we acquired our first AI tool from Cedars-Sinai, and it was a decision support tool in the workflow, alerting clinicians of evidence that based on, you know, ML and natural language processing in the chart, it would take everything about the patient, marry it with the evidence, and alert the clinician of a decision that should or should not be made. Clinicians do not want any more alerts. And so we had to go back to the drawing board with that tool and find the product market fit, which is first eliminate all the alerts, then maybe silently fire some alerts and see what they may or may not pay attention to and what is super invasive to their workflow. Then maybe put a few back in that make sense, are widely accepted, and are actually moving the needle, but constantly measure that, right, from a use case perspective. So I think that what you're getting at is we have to take a use case driven approach. You have your strategic roadmap, you have the pillars that, you know, kind of come after that. Where does AI make sense and where doesn't it?
Makes sense. So any hard questions you guys want to ask these guys? Making them squirm a little? No? All right.
I just
yeah,
want to
yeah,
throw
please.
in, because Cletus is probably freaking out that I didn't say it. So they're all, everyone that works at a hospital provider group, you have physicians using this. So please, here's the takeaway. Go secure it. Open Evidence will sign a business associate agreement. If you want to, I think they've also done, you know, a secured API. So if they're going to use it, pull the whole record in. But don't assume they want this integrated into Epic in their workflow and popping up on them. Just secure it for now, and let's figure this out with them.
And to be fair to the open evidence guys, there is a specific term in AI called alignment. Alignment just means that it is not like a general purpose LLM doing general purpose things, reading general purpose information, and providing general purpose responses. Open evidence is an aligned tool focused on things like PubMed, PDR, and the information store that it was trained on is literally evidence-based, right? So it's not one of those wide tools that will just pull in all kinds of information. So even if you didn't sign a special agreement, sign it specifically. So if you were, for example, a number of years ago, if you started using Perplexity instead of ChatGPT, things were better for you if you were writing papers. Like if you're a college student using Perplexity, you didn't get into as much trouble as if you were using ChatGPT. Why? Because the Perplexity alignment algorithms were different than the alignment algorithms. So it's one of these things where, and this is really good. I'm actually heartened to see two CIOs on boards, ex-CIOs on board, because then you can actually have these deeper conversations. It's not just AI, right? It's not even just LLMs. The peculiarities that we're going through, the localized LM rather than the cloud ones. So it's really, I think that does hearten me to see that we're not just kind of like willy-nilly talking about this stuff, but that we're talking specifically about actual technologies. So what are you guys hearing? We'll start with you, Cletus, first. Is what are the kind of questions your CEOs are asking you for your permission, if any, related to AI?
Well, again, it depends. I think depends on the type of organization and where they are and their journey, particularly in today's world around revenue and their status. Uh, what we are doing at One Brooklyn is really focusing how the AI tools in Epic can actually be used to help with more decision support. A lot of the things associated to quality, right, as well as revenue, right, prior auths, things that are naturally able to reduce the burdens, and have better quality outputs, as well as improving the revenue stance.
Mhm.
So the CEO and other executives are coming to us and giving us, we're the direction, right?
Mhm.
And here I am as the IT guy, so again, that's probably why you're seeing more of that, right? Being able to help them, saying, okay, yeah, that makes sense, or that doesn't make sense. It's a board, so it's not all on me.
Yeah,
It's a
yeah.
voted thing, but you help encourage the organization from a technology. We become almost the ultimate consultant,
Right.
right?
Well, do they feel better that you've cordoned it off to Epic, right? You didn't say, just go to anybody who's got any AI. You've already cordoned it off to Epic. Does
Yeah.
that make things easier,
It
or does that make it
does.
harder?
It does, because one of the things, and we've actually, when it comes to some of the revenue cycle initiatives, we've used other partners. We
Mhm.
went through you guys, right, and others, right? We go with, hey, we try to
Mhm.
look out, but for the most part, if we've made this significant investment in this vendor, and
Mhm.
again, sorry to name drop, but
Yeah.
it's a lot of money.
Yeah, of course.
Why go out and spend more money? Buy something else, give it a shot, and see if you can get that working. And again, reduce some of the outcomes.
Yeah, makes sense. And
So
so,
I have one slightly not contrarian view, but what I'm hearing from CEOs
yes.
that goes along with what you're saying. What aren't I seeing? What is happening in my market that I can't see in Epic? What are consumers searching for? What is leaking outside of my system that I can't see? How much money is that? What is the sentiment of my brand reputation as a system? So I feel like,
Absolutely.
right? I feel like a lot of CEOs are coming to us and saying, this seems like a useful, novel tool that we can use to identify our blind spots.
Mhm. And so, do you have any anecdotes about what blind spots you found that might have scared them?
So certainly, especially from a kind of patient acquisition standpoint, there's a lot of opportunity to sort of commandeer market share if you're in the right place at the right time. So most of it is more opportunistic, nothing that's scared them necessarily, but opportunistic to say, oh, wow, there's a great need in my community within a certain region for a certain procedure or a certain, menopause is a great example. Should we do a virtual menopause clinic? It looks like there are some pockets of, individuals that are maybe outside of the scope of my system today that we could better serve through, telehealth or whatever it is. So we're seeing some opportunistic um, patterns in the data that help them kind of inform their strategic roadmap.
Yeah. So, from your marketing lens, how many of the CEOs in your groups understand where GEO as opposed to SEO? So you can describe that to the audience just so that to know what that means. And what do you feel that their knowledge is of GEO and what impact that might make for them as the other side of AI, which is somebody else is using AI and do they show up in their AI or not? So if you can describe that and maybe what you
Sure.
guys have talked about, would be great.
So very simply, SEO is what we used to do to optimize the search engine, and GEO is what we do now to optimize results in a LLM like ChatGPT or Perplexity or what have you. Um, Very limited understanding of that from the CEO perspective, but you're seeing marketing teams manipulate it. I'm getting more requests. How do I reduce my spend on corporate services like marketing or finance or RCM by deploying AI, which is possible. I actually just built an entire AI marketing team with bots, agentic AI for a company that I advise. It's possible if you have your value proposition nailed down and your product market fit perfectly aligned, then you can plug all of that in and flow it through. But you have to have the strategy. The strategy has to drive everything. So the point that you're making is consumers are in there. Just like clinicians are using open evidence, consumers are using ChatGPT to put in a diagnosis and to get a diagnosis about symptoms that they have. So how do you really capture that market share and try to, get them into your system for the appropriate care?
Can I jump on that GEO piece?
Yeah.
It's so transformational, and I don't know if a lot of people know about how right now, before when you used to Google, right? You Googled and you looked something up. But right now, based on the first results that come up, most people are not even clicking on the link because of the generative optimization that's occurring, right? So they just click on the first link. They're not clicking on your website anymore. So we have to, right? Am I wrong? Right? So we have to change the whole the whole dynamics, and that's what we're asking for, right? From a board, like, what are you doing to change this? Because if we know the world is changing in front of us, then we need to, whether you're looking up services, for the health system, you need to now change your front end so that you can accommodate this new methodology of first lookup, right? And that's powerful. People are no longer clicking the Google, the O's, the other, the third, fourth O's. They just don't do it anymore. So you have to be more efficient.
Yeah, and so Tom, from your perspective, you see there's a lot we've talked about in terms of us using AI in an offensive way, but AI you have to do defensively as well for these kind of GEO activities. So what has your advice been?
Well, I've been pushing a lot of what you're saying, although I don't understand the GEO, so it's good to hear that from both of you. But I've been waiting for the shoe to drop on ChatGPT Health and Claude, and it did. And
You want to
yeah,
explain that a little bit?
I'll explain that a bit, but because you mentioned the patients are already using the tools. So ChatGPT claimed 40 million patients a day use their tool for health-related searches. 40 million people a day. So they're doing it already. And so what they announced with ChatGPT Health was a special tab with special security. Now, take this as you will, that would download your data, and you could use ChatGPT with some special learning added. So it's not the regular ChatGPT. It has some specific health database research, but you could download your entire record there. They promise to be secure with it, not use it for training, et cetera, say all the right words. But the instant you download the record, it's not covered by HIPAA. So it's important to remember that. You've said, here you go. They're not covered by HIPAA. But anyway, the idea of the tool is spectacular to me. Because first they partnered with Be Well, which is a company that aggregates some data and claims to. This all doesn't really quite work yet, but nonetheless,
but
it's
it will
there.
soon.
Yeah, it will. So I can pull my record from everywhere I've been, theoretically. So I've got, now I go to a portal or three, and, we heard the other day, wow, 20% of, 20% of the types of visits could be, I think it was, I don't want to pick on who it was actually, because they were an outlier for being so high, that you could schedule 20% of the types of visits. And you could look at your record at just that site. Well, they're now saying, here's your whole record, and you can do all kinds of cool things with it. So the next time you get a lab result, instead of going into ChatGPT and saying, so what the heck does this mean anyway? You can say, not only what does this mean, but chart that out for me. So my doc says that high. Was it always high? What's happening with it? Can you trend that? It will just do all those things. We might actually get a tool that's useful to help with your care, and that's not where I want it. Just to be clear, I'd like to see health systems go.
That's
create
the
that.
opportunity.
Yes.
And that
That
is
you were pointing out.
exactly the point, is that consumers still don't trust ChatGPT. They trust One Brooklyn, right? They trust their doctor.
Yeah.
They trust where they get care, where they get life-saving care. And so imagine as a health system or a hospital, you having that LLM or agentic experience that the consumer wants on your digital front door. That's where I feel like we really need to go, because trust is going to be the friction point in why consumers are still going to take what they get from ChatGPT and bring it to their doctor.
Exactly.
Can you validate
But
that this is
yeah,
right?
this is a huge opportunity, and almost no providers have added the LLM aspect or the pulling in the other record. That's the key here too. So if you're Mount Sinai, to pick on them, and you don't want to pull in the records from NYP, well, suck it up. Give them the whole shebang there, and maybe they stick with your app or your portal. NYP has, well, they both have apps. So, it still has my chart underlying, but let's expand what we can do here. This is the opportunity to do it.
And that's what I want you guys to hear, that these are the conversations that are happening at board levels. But Greg, please.
It sounds like third parties are going to be all over this, because I don't think the health systems are going to do it themselves, unfortunately. So probably a third party. But what about the payers? I mean, they have been non-players in all this stuff. I'm sorry, I'm pointing at Mohan, but
No, Mohan has to speak for every payer.
I mean, wouldn't they benefit almost the most? I mean, for most people, you're going to have somebody go get all this stuff. You're not going to go get it all yourself. Let's be honest.
Yeah. Well, that's what
that'll be 10% of the people, and they don't need the information probably. But somebody's got to accumulate it and aggregate it, and then somebody's got to monetize that, and it's probably either through the payer. I don't think they're going to monetize it through the health system.
Well, I think it certainly could be, because as you said, this is our opportunity. They're trusted, and there are studies showing that absolutely, even specifically with AI, while consumers still don't trust their health provider with AI, they trust them more than anyone else. Yeah. So there's a start there, but also ChatGPT, and by the way, just to be fair, immediately after, Anthropic has a tool called Claude, that also announced similar, but both those tools will pull the whole record for you. You don't have to deal with that.
Yeah, because they've partnered, just to be fair. It's not like they built all of this, this environment that that has been building out for a while. So ChatGPT, OpenAI is using BeWell, BeWell.com. You can see them. Josh Mandel from the Microsoft team, just about 2 weeks ago, he did it with his own record, and he actually published the results on LinkedIn. It's a very cool little reading, because at first he tried it and everything broke, just like Tom was saying. But then he talked to the BeWell team, and like luckily he kind of like documented this in public on LinkedIn. It's worth reading, because he talks about what benefits he got from it and what were the detriments. But I agree with your point, and if Mohan, if you have if you want something to say about it from the payer angle, we'd love to hear that. And by the way, Mohan, don't give it from your opinion as a innovator that has been pushed aside many times from the payers. Think about it as a normal payer. They're like, no, I'm not doing any of this. Or they're like, no, this is one of the first things that I would do. So, go back to your AHIP days and say, what would the most of the payers be doing in this case?
Yeah, I mean, I was lucky, right? I reported as CEO. So as Chief Innovation Officer, I got a lot of carte blanche to drive the kind of transformation I could. But even if you drive it on one side of the business, like the blues is all over the US, driving it on one side of the planet, it finds a way to make the status quo more important. And it's fundamentally the payment model. It controls the flow of money and therefore the flow of behavior. So when you introduce consumer tools, like I did multiple times, introduce transparency tools, they all fail under the weight of payment models. And so they expel those technologies into startups, and those startups get funded. I should have gone with them. And some of them have liquidated at incredible prices. So look at me, I'm hanging out with you guys. So you can see I made mistakes. But the fact is, the answer to the question is, when I was in the payer world, everybody would say, isn't this valuable for you as a payer? Everything, like from getting a different kind of fruit into the diet, they'll say, you ought to pay for that because downstream, it really makes people healthy. The payers look at it and go, heck, you don't even stay with me long enough, right? It's everything you're talking about is long-term. the average stay that a consumer stays with you is not longitudinal enough to see the impact. And everyone's measuring the return on investment at a much shorter period of time, probably 3 years. And that's the average time a patient kind of hangs with you, and then they move. So the storyline is, and I'm going to be a little direct about this, not representing me, but the payer model when I was there. Hey, if it's so valuable, why are you giving it to us? You should pay for it yourself. Now, the issue of trust, I think the healthcare system has failed the consumer. And it has failed it consistently over time. And the healthcare system has enjoyed it and tried to survive as an institutional entity, building little keiretsu relationships with everybody. The consumer has been tracked like grass when elephants are fighting. It's been flat. And the consumers got pissed. All of a sudden, OpenAI came in and said, we're a better devil. We won't hurt you, but we'll just steal your brain. That's about all we're going to do. But we give you all the convenience in the world. So when people ask me, what's my opinion about AI coming in the LLM form? I'm like, you deserve it, you healthcare system. You should have listened to the consumers a lot earlier. Now you're catching up with them, and now they own you by the LLM, right? And if you own the customer by the LLM, you're not going to suddenly, if the payer started a website tomorrow, and I'm sure it'll be colorful, they'll hire me as a consultant, I'll make it nice. And what will happen then? You think consumers suddenly say, what I've been waiting for all my life to join a health system with a beautiful website? They'll say, screw you. I'm sticking with the thing that helps me choose my dinner, do my homework, and help my kid, plus also give me medical help. So I think the train has left the station a long time ago. Consumers are not going to trust us anymore. So how do we get it back is the deeper question. The physician is not the trusted member in the healthcare system. The pharmacist is. They are closer to the ground than anyone else. And combine the two together, they have power. So I don't have an answer to this, but OpenAI has found a crack in the system, and all of the LLMs are being shoved up our healthcare rear end. And now we have to find a way to bring it back and earn the trust, not just the intellectual capital. And I don't have an answer to that, but I think it's a great challenge for us. I think it's something that we're on the side of right to make this happen, because I can tell you LLMs are not right. They smell, there's something smelly there, right? Because they're going to own you completely. I don't want to put them down. I don't want to insult them, but I say LLMs by itself don't have the compassion that I know you all have. The compassion, the caring, the future-centered, the cause that you carry, they don't have. They don't know what that means. They are not in that DNA. So we need to own it back. And I don't know how to do it, but I want to work with you on it. I want the help.
No, I love it. Any last minute? We have we can take one more question.
I just want to make one comment in rebuttal to what I always hear from payers about. They're looking at 2 years. If you guys are so damn smart, how come your actuaries can't use AI to figure out how to get an ROI in 2 years? I mean, it's got to be some of us who can get an ROI in 2 years.
Fire the actuaries.
Yeah. Megan, do we have one? Did we have one more question?
I
thought I heard.
I was just gonna second the lack of trust. I mean, 5 people here at this conference told me my primary care physician just rolls out the paper. I get 15 minutes. I mean, we can't be cavalier with saying that the premiums are up, you pay a copay, right? Trust is a sacred commodity. And if we're gonna have some building blocks on it, we got to be transparent that the health system has lost it, right? But it can get it back, because guess what? People need it.
And if they don't, watch out for the payer, because they have access to the data to have a very customized conversation with the consumer and draw them in and get trust. So I think as health systems, we have to leapfrog.
Right. Which takes it
Big-
back to
big
the
round of-
first
whoop.
session,
Sorry, go ahead.
which was what Lisa had to say, which is that change starts with trust.
Yeah.
So we can take it full circle.
Full circle. All right. Big
Change
round of
maker
applause for our
awards.
last panel of the day.